Welcome to this BSN Nursing Study presentation for Exam 5. We will cover grief, loss, defense mechanisms, and the stress response, aligned with ATI standards. First, let's review the different types of grief. Uncomplicated or normal grief is the expected healthy response to loss. It includes sadness, anger, guilt, and physical symptoms like sleep changes or fatigue. Intensity gradually decreases over weeks to months, and anniversary reactions are still considered normal. Anticipatory grief occurs before the actual loss, such as with a terminal diagnosis. It allows time for preparation, saying goodbye, and completing unfinished business. It can sometimes soften the grief that follows. Disenfranchised grief is grief that society does not fully recognize or validate. Examples include the loss of a pet, a miscarriage that others minimize, or the death of someone in a non traditional relationship. The person may feel isolated or that their pain is not legitimate. Prolonged or complicated grief lasts beyond the expected time frame, often more than 6 to 12 months, and significantly impairs daily functioning. The person may remain stuck in denial or anger, experience intense yearning, and is at higher risk for depression and suicidal ideation. Safety screening and referral are essential. Next, the 5 stages of grief described by Elizabeth Kubler-Ross: denial, anger, bargaining, depression, and acceptance. Remember, these stages are not linear. Clients may skip stages, go back and forth, or never reach acceptance. The model helps us understand emotions, not dictate a required sequence. In denial, the person experiences shock and disbelief. In anger, feelings may be directed at self, others, or caregivers. Bargaining involves negotiating for more time. Depression brings profound sadness and withdrawal, where suicide risk assessment is critical. Acceptance involves coming to terms with the loss and focusing on practical matters or legacy. As nurses, we meet the client where they are. We never force progression through stages. Therapeutic presence and safety are priorities. Now, defense mechanisms. These are unconscious strategies that protect the ego from anxiety. Projection means attributing one's own unacceptable feelings to someone else. For example, a client who is angry may accuse the nurse of being angry. Repression is the unconscious exclusion of painful thoughts or memories from awareness. It differs from suppression, which is conscious. Rationalization involves creating logical but false explanations to justify feelings or behavior, protecting self-esteem. Regression is returning to earlier, more childlike behaviors under stress, such as an adult becoming incontinent or a teen clinging excessively. These can be adaptive short-term, but become maladaptive when they interfere with reality testing or growth. Avoid confronting defenses too early. Adolescent grief often looks different. Teens may show risk-taking behaviors, academic decline, withdrawal from family while seeking peers, somatic complaints, emotional volatility, or feelings of guilt and identity confusion. These are common expected responses. Always assess safety for self-harm or substance use, and involve the adolescent in age-appropriate decisions. Maladaptive or complicated grief is marked by intense, persistent yearning that interferes with life, inability to accept the reality of the loss, functional impairment, and elevated risk for psychiatric disorders. Always screen for suicide risk and facilitate referral to specialized support. Let's turn to Selye's General Adaptation Syndrome, or GAS. The first stage is alarm. This is the fight or flight response. Heart rate, blood pressure, and respiratory rate rise. Pupils dilate, blood glucose increases, and the person becomes hyper alert. The second stage is resistance. The body tries to adapt and restore homeostasis while remaining on high alert. Hormone levels stay elevated. If the stressor continues, resources begin to deplete. The third stage is exhaustion. Adaptive energy is gone. The person may experience profound fatigue, immune suppression, organ strain, depression, or burnout. Early intervention in the alarm or resistance stages can prevent reaching exhaustion. Finally, acute versus chronic stress. Acute stress is short-term and time-limited. Being the victim of a crime is primarily an acute stressor, though unresolved trauma can become chronic or lead to PTSD. Living in poverty is a classic chronic stressor. It is ongoing, with continuous activation of stress systems and cumulative health effects. Losing a loved one begins as acute stress and grief. For most people, it remains adaptive. If it becomes prolonged and impairs function, it shifts into a chronic stress response. Key takeaways for your exam and practice. Grief is highly individual. There is no single correct timeline. Safety is always the priority. Therapeutic presence and validation matter more than trying to fix feelings. Differentiate adaptive from maladaptive coping. Early recognition of complicated grief and chronic stress allows timely intervention and referral. Thank you for reviewing this material. Use these concepts to provide compassionate, evidence based nursing care to clients experiencing loss and stress.